All right, and we're live with a very special Haute MD session today with Dr. Levine. Thrilled to have you here with us today.
Thank you for having me.
As we let everyone tune in, I just want to ask you a question just to kind of start out. What's your biggest takeaway been in these last 6 months, both professionally and personally?
Well, first, thank you for allowing me this opportunity to speak to such an amazing group of individuals and such a great audience. During the pandemic, I think we've all learned to stay humble. I think we've learned that all of the lessons that we learned about infectious disease and viruses have been evolving. And during this time, during this pandemic, we've learned so much about how to take care of patients safely and effectively and efficiently. We've also learned so much about COVID. But I think the big takeaway has been stay humble, because you can't really make any assumptions. It's really what you learn through your experience of taking care of patients and being in a city like New York that was the epicenter of the disease, where you learn that every day can be a little bit different than the last day, and you have to learn from your experiences.
Well said. What about personally?
So I think personally, it's been, you really have to think about what would it be like to be a patient during this time. It's hard enough being a patient. Although I think that our office is very nice and our staff is wonderful, and I try my best to be as friendly and upbeat as possible, no one really wants to come to the fertility doctor. No one really wants to be sitting here. And as people have been going through the pandemic, there's been a background of fear and angst and anxiety. And so I think personally, I've really tried to put myself in the position of the patient, knowing that it might be a struggle to want to just leave your apartment and seek help for something that should be so natural and so easy, and seems to come so easily for so many people.
Thank you so much, Dr. Levine. We're so thrilled to have you. Were you seeing patients virtually during this time? How did you operate during this time as a business?
So when things started getting weird in March, and specifically around March 13th, we recognized that we were going to have to change the way that we practiced medicine. What we did was we started developing a hybrid model where only the essential services would be provided, and whatever we could do virtually, we would do. So many of the new patient encounters or the new patient appointments would be done virtually, where we would talk to the patients and learn about their history, or follow-ups or going through results we would do virtually. Of course, when it came to blood work and ultrasounds, we'd have patients come in, but we would stagger them. So we've been doing a hybrid the whole time.
Thank you so much. Well, we're sure thrilled to have you and your partnership together with Haute MD, and to have a good hour-long session with you today. So thank you so much.
Well, thank you.
On behalf of Haute Living and the Haute MD Network, I'm April Donaldson. I'm our Senior Vice President here at Haute Media Group, and we're just really thrilled to have you with us. So to begin, Dr. Brian Levine is the founding partner and practice director of CCRM New York. He is a board-certified reproductive endocrinology and infertility and obstetrics and gynecology. Dr. Levine leads the industry in normalizing open dialogue about infertility, a medical condition affecting 1 in 8 couples, and educates prospective parents on a national level. Over the years, he has been cited as one of the nation's leading fertility experts in the New Yorker, New York Post, NBC, CNN, Avenue Magazine, amongst others, offering valuable insight on everything from fertility, misconceptions, egg freezing 101, to how men can boost their fertility. Dr. Levine, thank you so much.
Thank you for having me.
So to start out, what should patients be looking for when choosing a fertility clinic or doctor?
So first and foremost, when thinking about going to a fertility clinic, I hope that patients recognize that their success is the clinic's success, and that clinics and doctors are partnered together. Without patients, we wouldn't have a business, and without fertility doctors being present, many patients wouldn't be able to get treatment. So they should be looking for a clinic where they feel comfortable, because infertility is a very sensitive topic, right? This is typically something that happens in the privacy of your home or in the privacy of, call it your most intimate moments in a relationship. And now you have to go to a fertility clinic and seek help for something that seems so natural, but now needs to be reevaluated and really, looked at piece by piece. So my big advice for everyone is go somewhere where you feel comfortable.
Thank you, Dr. Levine. And what were you going to say?
Sorry. So I'd say the other thing is important to know is that there are many different systems that are out there to help you understand where to go for a clinic. One of the great things about reproductive endocrinology and infertility, the field that I'm in, is that we have an organization out there called SART, the Society for Assisted Reproductive Technologies, and they publish success rates. It talks about the success rates of a clinic on a very objective level. That's one place that you can go to learn about the clinics in your area. You can also take a look at websites like Fertility IQ, a fertility website that's completely dedicated just to patient reviews of patients who have been verified who attended that clinic. From these two sources, you can start to learn of what might be the right fit and what you might need to get the best outcome.
Thank you, Dr. Levine. Are there any early indicators that men and women could be looking for signs of infertility?
Absolutely. And this is probably one of my most favorite questions because many people feel like they only learn about infertility when it's too late. Well, first and foremost, it's important to understand that for women, if you're off the birth control pill, having a regular cycle, which means getting a period every 28 or 30 or 32 days, some sort of regular cycle is a good sign. And if you don't have a regular period, maybe talk to your OBGYN about it. If you're on the pill and the pill doesn't hurt your fertility whatsoever, but if you're on the pill, you should know that the pill can be giving you a fake period or a synthetic cycle and might be preventing you from learning what your body naturally would be doing. So when you go for your annual checkup, maybe talk to your doctor about other things you can do to be evaluated. For men, sexual health and sexual performance is something that most doctors unfortunately don't talk about. But I do think that in this society, we start to becoming increasingly aware when things seem different. If your body seems different, or you notice that either your sexual performance is different, or maybe you're having issues with sexual relations, for example, talk to your doctor about this. Talk to your doctor during your checkup. There are certain medical conditions that can be treated. The other thing to know is that for both men and women, is that if you are having any pain or discomfort, you don't have to blow it off. For example, frequently a man will say that he's had an aching pain in his groin. Maybe he pulled a muscle, or maybe it's something else. And we hear this story quite often. I would say is bring it up with your internist. It could be something very treatable, like something like a varicose vein that has to be treated by a urologist.
We have a question that just came in from an Instagram user along these lines. Over to diet. Does diet make any difference in infertility?
Absolutely. So there's some really cool literature that demonstrates that the anti-inflammatory diet, which everyone always asks me about, like what is the fertility diet? Is really the anti-inflammatory diet, which put in kind of a better sense is really just the Mediterranean diet. I always tell my patients that the 4 W's are the 4 enemies when it comes to fertility: white sugar, white rice, white wheat, and skim dairy products. The reason is that those 4 things have a very high sugar content. And we know that sugary substances are very inflammatory. That inflammatory environment can be counterproductive to getting pregnant or staying pregnant. We also know that in both men and women, if you're slightly overweight, that can affect your fertility outcomes. Many studies have demonstrated that adopting a more Mediterranean diet, which means, fresh fish, fresh vegetables, less processed foods, for example, are associated with better fertility outcomes.
Continuing along those lines, and thank you so much for that from an Instagram user as well. Would you recommend for a healthy woman under the age of 35 with no irregular genetic history to opt into amino-CVS for peace of mind? They're not concerned about a miscarriage, but more so for amino complications that could hurt an unborn baby.
So this is a really powerful question, right? So here we are in the midst of a pandemic and everyone's saying, all I want is a perfect child, right? That's what everybody really says, is they just want a healthy, perfect child. So you go to your doctor and your doctor says, okay, if you want a perfect child, you have to do this CVS, which is called a chorionic villus sampling, which means they check the placenta at somewhere around 10 to 16 weeks, and they take a little biopsy or sampling of that placenta. Or they do an amniocentesis, where they stick a needle into the woman's belly between 16 and 24 weeks. Those two tests give very similar information, and the information that they both give is the genetic makeup of the child that is being carried. With that said, no test is perfect, and sometimes too much information can actually be a problem, right? Sometimes you can get some information where you actually don't know, is that good or is that bad? So instead, what I always tell patients, that if you're grappling with, should I do a CVS or should I do an amnio or do I have to do anything? Remember two key things. The first thing is, you should know that in the United States, we are incredibly focused on screening pregnancies. In fact, we screen pregnancies at 10 weeks by blood work. So if you've had blood work that's reassuring and the rest of your testing comes back normal, talk to your doctor about why you need this more invasive test. And like the user asked that question, of course, some of these tests do have risks of losing a pregnancy or complications. The second thing to think about is to know that there are certain risk factors for having things. So go seek genetic counseling. Talk to a geneticist. Learn if you have a risk of getting something. Do you have a risk of passing something to a child? Do you really need this information? Because I'll tell you that our ultrasounds are getting so good that sometimes you don't need something invasive when you could do something that's non-invasive.
Thank you, Dr. Levine. Is there anything that you're able to do to prevent like umbilical cord complications?
Great question. So along the same lines of what I just brought up, that our ultrasounds keep getting better and better and better, right? I mean, now when you're pregnant, sometimes you can even get a picture of the baby's face on 3D or 4D. Well, what happens is that we're actually now starting to get really good at looking at the umbilical cord. And the classic example would be the umbilical cord is supposed to have 3 blood vessels within it, and it's supposed to attach right to the middle of the placenta. Think of kind of like a pancake with the cord coming right out the middle. Well, because our ultrasounds have gotten so good, we start to see that maybe that umbilical cord is moved to the side, or maybe it's on this way or this way, and maybe it just kind of has an alternate performance. Well, what I would say is there's nothing you can do to help or hurt that process, except I would say make sure that you are being seen at a practice or facility that is comfortable doing advanced ultrasounds. And I would say it's probably good to get an evaluation with a maternal fetal medicine specialist or a high-risk obstetrician.
So would something like that prevent pregnancies where, you know, the parents lose the baby due to strangulation from the umbilical cord?
Right. So
because of that?
So that is kind of everyone's big fear, is, you know, losing a baby from the umbilical cord getting caught around the neck. And what we do know is that the reason that happens is the fetal positioning and sometimes in labor. And we can't always see with ultrasound if the cord is wrapped around the baby's neck or not. Unfortunately, we're still not at the place where we can screen to prevent this from happening. But with your obstetrician, you'll likely make a plan for what's called kit counts, and you'll make sure that you feel good fetal movement. And what we do know is that if, God forbid, any of these strangulation processes occur, what happens is that the baby's movement tends to change and drop down slightly. So people would become more aware of the change in the fetal movement and alert their physician.
Great. Thank you, Dr. Levine.
Of course.
Lots of questions from Instagram. What's a good time to start considering freezing eggs for women?
So I love this question, right? This is probably the number one question that I get every day. And the truth is, you'll never be as young as you are today, but the best time to freeze your eggs is when you start thinking about it. Now, the truth is, if I had to pick the ideal age to freeze your eggs, it would be 32 years old. And the reason is that as you get older, your egg count goes down. And that's pretty clear. Well, as you get older, the chance of problems starts going up. So you have egg counts going down and you have problems going up, and they tend to cross over somewhere around 35. Right? So what we like to see is that people freeze their eggs comfortably before 35, when the chance of having a problem is pretty low and their chance of having a good egg count is pretty high. With that said, whenever you think about freezing your eggs, is the right time to talk to your OBGYN. Get blood work, get an ultrasound. And every clinic should be able to offer patients data about their success rates. So a patient who I saw today, for example, was 37 years old. She said, "Did I miss my window for freezing my eggs?" And I said, "No, because the truth is you're your youngest today that you'll be, and let's evaluate you." You just counsel the patient that she'll likely need more eggs frozen for the future than she would have had she been younger.
Thank you, Dr. Levine.
Of course.
More questions from Instagram. So women that are in the middle of infertility treatments and with a new COVID vaccine coming out, would you recommend to someone to get the vaccine if they're in the midst of these treatments?
So this is probably the most difficult question that I've had to deal with during the pandemic, because the answer is I don't know. In fact, on Sunday evening, I had a fascinating conversation with someone who's on one of the US government teams that's developing the recommendations for the COVID vaccine for pregnancy. As far as we know to date, there is no data on the safety or the efficacy or the efficiency of the COVID vaccine in people who are in early pregnancy, currently pregnant, or breastfeeding. As a result of the lack of that data, I cannot recommend that someone get the vaccine today if they're getting pregnant in the near future, or currently pregnant, or breastfeeding. However, what we are seeing are a lot of patients coming in saying, "I want to freeze eggs and I want to freeze embryos so I can then go get the vaccine. And then after I get the vaccine, I then want you to help me get pregnant down the road," which we never expected to see that. And this is a new phenomena.
Thank you, Dr. Levine. Going back over to the beginning of this session when you were speaking about the ratings of, IVF doctors and clinics and so forth, when do you recommend a woman seeking a second opinion or switching clinics if she's not been successful in yielding a healthy pregnancy? What's the time frame?
So it's really hard to leave a clinic. And the reason is that you invest so much time and effort. And the truth is, many of the treatments that we do are both diagnostic and therapeutic, right? I mean, you go through these cycles and we see how you respond to medicine and we learn things about you and how you're responding. And therapeutic because we hope to throw all that data away and get you pregnant. But truth be told, life is not baseball. And you don't need to have 3 unsuccessful cycles to pivot and go to a new clinic or to go to a new doctor. If you feel like your questions are not being answered, or you feel like you're being put through a factory and you don't know what is your next step if this one doesn't work, my humble advice is go get a second opinion. Because of COVID and because of the pandemic in general, many of us, including myself, are now offering telemedicine appointments earlier and later than we ever were seeing patients before. You can now see more doctors easier than ever before. So you can get a second opinion while you're still with another practice. So I advise everyone that when in doubt, reach out.
Thank you, Dr. Levine. More questions from Instagram. How soon after the birth of a first child would you recommend freezing eggs for the second child?
So it all depends if someone's breastfeeding or not. Classically, if you're breastfeeding, we don't recommend you going through the stimulation process for egg freezing or IVF. With that said, if you've completed breastfeeding and you had your period come back, which could take up to 3 months after finishing the breastfeeding process, you're okay to go freeze eggs or embryos. And I will tell you that because of the pandemic, we've had many patients shorten the window of how long they want to breastfeed, and then they've frozen embryos. And it's not that they want another kid right away, They just want to have some embryos frozen so they can then go get the vaccine and put it back at a later date.
Thank you, Dr. Levine. What are the first recommendations that you make to someone that feels that they might be having trouble conceiving?
So my first advice is to take a deep breath. Many people think that just because their dumbest friend or their most careless friend or their silliest friend or the person that they think is the least put together got pregnant so easily that it's just not fair that they're not getting pregnant. And what I remind everyone is take a deep breath and recognize that many people lie. Many, many people say they just looked at their husband or they looked at their partners and they were pregnant before they knew it. Truth be told, it's actually relatively difficult to get pregnant, right? Most of us spend the majority of our teen years and college lives and 20s even avoiding pregnancy at all costs, taking pills, having procedures, putting in IUDs and things like that. However, there are pretty good definitions of what infertility is. If you are trying to get pregnant and you don't get pregnant in a year because you're under the age of 35, go seek help. Talk to a doctor. If you're over the age of 35 but under the age of 40, that's moved down to 6 months of trying with no luck. And if you're over the age of 40, I would say that if after 3 months you're having trouble getting pregnant or staying pregnant, go seek help. However, fertility is one of these things that is, based on performance, right? The only way to really diagnose infertility is someone's ability to either get pregnant or stay pregnant. But there are blood work and ultrasound and semen tests that we can do to help guide someone to know if they should be having an easy time or a difficult time getting pregnant. So if you really want to try to figure it out, talk to your OBGYN or talk to your doctor.
Thank you, Dr. Levine. What are the emotional side effects and differences between men and women who are trying to conceive and they're not able to? What are the differences between the genders and emotional side effects?
So in someone who practices the treatment of couples, which, right, there's very few fields in medicine where you have two patients at once. I have to say that one of the most difficult things to do is to sometimes tell a couple that we can't figure out what is going on just yet, the unexplained infertility. Because people come to us to ask for what's wrong and what do we have to do to fix it. And sometimes despite all the testing and all the evaluations, we still aren't able to find an answer just yet. And we will find one maybe with further treatments or further evaluations. But typically what you see is that on the female side, females sometimes hope that it's them because there's such a normal stigma in this country that infertility is a female disease. And then when we find out it's a male factor or it's a sperm problem, we find that quite often the male partners tend to recoil, right? They kind of pull back. And it becomes almost a matter of shame or embarrassment. Well, what we try to do here, and I know my partners and I really focus on this, is helping normalize this conversation and helping people understand that if you were to take 100 people with infertility, you take 100 couples, for example, 40% of them will be dealing with male factor problems, the quality of the sperm or, sexual performance or whatever, male factor infertility. 40% of the time, it'll be female stuff. The woman might be older, it might be egg quality, might be uterus. And 20% is that unknown or combined, where we're trying to really figure out what's the root cause of it. But I will say that from a psychological standpoint, it's tough. When a couple goes through IVF or in vitro fertilization, it's very interesting to see that many of the husbands wish they could be the ones taking the shots, right? We all know that IVF requires some pain, right? There's the shots that people have to take, the uncomfortable ultrasounds people have to have. Sometimes it's, these vaginal suppositories of hormones. And, some women say openly that their bodies feel out of whack for going through the process. And what I do see quite often is that many of the partners wish they could take it away from their wives, right? We could be seahorses and, let the men carry the pregnancies and deal with all of it. And I do think that the emotional toll that it plays upon male partners is real. But I don't think as a society we do enough to talk about it. We don't talk about the struggles that men go through as they're watching their female partners deal with infertility, or men who are diagnosed with infertility.
Thank you, Dr. Levine. This is a question from a male. Looking to freeze or cryo sperm, is there a specific diet that you recommend prior to the storage?
So what we do know is that alcohol and smoking are probably the two worst things that you can do for your sperm. However, I don't know how you get through this pandemic without alcohol, right? Everyone needs to do something to take a break. So what I would say is it's alcohol in moderation. Maybe it's a glass of wine, one night of the weekend, or 2 glasses of wine. But I would say it's drinking in moderation. What we do know is that smoking marijuana, smoking cigarettes, smoking cigars, all of these things have deleterious or negative effects on sperm quality. And the reason is that anything that reduces the amount of oxygen in the body will greatly affect the sperm quality. Furthermore, what we do know is that when it comes to diet, a very fatty diet is a negative diet for sperm quality. You want to try to be as lean as possible. You really want to try to be as healthy as possible. And the reason is that as we gain weight, what will happen is we'll increase the temperature of our body. And the sperm are incredibly sensitive to temperature. By the way, this is why many men have had infertility as a result of COVID-19. But the body is very, very sensitive to temperature, and so are the sperm. So if you could do anything before freezing your sperm, don't smoke, limit your drinking to as much as possible, and try to eat an anti-inflammatory Mediterranean diet.
For a couple that's had a continued cycle of negative retrievals, how do you determine if it's the sperm or the egg that's the issue?
Great question. So with every patient that I have that goes through IVF, I make a point of going into the laboratory and talking to the embryologists, talking to the experts to say, hey, how do the eggs look? How's the sperm look? And then, of course, I also look under the microscope myself. But sometimes it's much more than just how things appear, right? You can't judge a book by its cover. And you can sometimes learn that if they have a bunch of eggs retrieved, but not a lot of embryos resulting in the end, maybe it's a fertilization problem. Maybe it's the technique that's being used. Maybe it's actually not the patient, but it's the doctor who needs to pick a better recipe, a better cocktail to figure out what's the right approach for this couple.
And then going back to what you said at the start and the grades between doctors and clinics, I mean, obviously clinics and doctors have more success than others in the whole process.
Correct. So, a lot of clinics openly will tell you that, they're loved by everyone and hated by no one and yada, yada, yada. Well, you know what? That's why there's some really good resources out there that are objective, looking at SART, looking at the CDC, the Center for Disease Control, where we have to publish our results, looking at fertility IQ. And you can really start to see on there where certain types of patients and populations tend to excel or not do well.
Thank you, Dr. Levine. What are factors that both men and women can do on their own to increase their fertility?
Great question. Everyone says, look, how can I avoid seeing you? Right? Like, what can I do to make sure I don't end up in your office? So I think one of the big takeaways so far that we've talked about is diet, 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 right? So limit the sugar, limit the crap food, really try to adopt a healthy lifestyle. Truth be told, there's very little that you can do to positively or negatively impact your fertility with just lifestyle. But with that said, if you can adopt the Mediterranean diet, and if you take like a simple multivitamin, that can make a big difference. Unfortunately, there's a very big market out there, and people play to this on Amazon and other websites of trying to get you to take all these fertility vitamins and supplements. Many of the supplements don't make a big difference. So what I would say is don't go nuts with supplements. Really just take a multivitamin every day, try to get some sleep, and maybe try to figure out what you can do to make yourself better. What I'll tell you is that during the pandemic for me is I started wearing this thing called a Whoop band. And one of my patients taught me about this. So I wear this band every single day. And what it does is it tracks my physical activity, but for me, I'm using it to track my sleep. And what I have learned what foods work for me, and when I can drink or not drink, and what I can eat or not eat to get a good night's sleep. So for example, today I had this crazy busy day and I get to end my day with this great interview with you. So I want to make sure that I was going to end up in the green tonight for my sleep. And so literally, I will show you the proof. I ended up in the green because I knew what I had to eat last night and what time I had to eat my dinner last night to make sure that I got the best sleep possible for today. And so I'd say is understand that fertility is kind of like training for a marathon, right? Get your body in the best shape, train for it, and you'll perform the best.
Thank you, Dr. Levine. After someone's gone through IVF, it's been successful, they've had their child, how soon after that can they begin a second round of IVF to conceive a second child?
So this is, I think one of the most challenging questions that we get. And the reason is that it's hard to tell someone to wait without a reason. And there aren't many reasons for why we say, wait, don't wait. What we do know is this. If you've had a cesarean section, we really would like for it to be a full calendar year, one full year from delivery until you get pregnant again. And the reason is that we want that uterus to really heal, and we want the muscle fibers to come back together to make sure that you're creating the best environment possible for getting and staying pregnant. On the flip side, we know that pregnancies are really parasitic, right? They take everything from the mother. They take away most of the nutrients. They take a lot of calcium. There's also an element of blood loss that happens at the time of delivery. And so you want mom to get her body back into the healthiest place possible, not just for her own maternal health, but to be healthy for the second child. So in general, what I tell people is that wait at least a minimum from a year from when you delivered to think about putting back that next embryo. However, if you want to create more embryos and maybe delay that even further, that's totally fine. Just make sure you're not breastfeeding.
Thank you very much, Dr. Levine. Is there any research or feedback on wearing an iWatch and how it would possibly or potentially impact fertility?
Absolutely. So there's lots of data that's coming out about wearables. And that data is not really in the fertility literature yet. That data actually comes out a lot in the diabetes literature. And what we know is that in people with type 2 diabetes, right? Type 1 you're born with, type 2 is the one that you get later in life that you acquire, was that you can actually reverse diabetes or the metabolic syndrome by using something like an Apple Watch or a wearable. And the reason is that people tend to be more active with it. Well, as you and I were talking about before, one of the best ways to get your body in the best position for getting pregnant and staying pregnant is to increase your physical activity. So an Apple Watch or a wearable device that gives you data that's actionable is definitely going to be something in the positive for getting and staying pregnant.
Thank you very much, Dr. Levine. And I know you touched on this a little bit at the beginning about, having too much data and finding out too much information and thoughts on that. What are your thoughts on genetic testing overall as a whole on embryos?
So I love data, right? Deep down inside, if someone, were to ask me, how do I sum myself up with one word, I would use the word geek. I am just a data junkie because I think that it's through data that you can make decisions where you try to remove the emotion. With that said, the word genetics is a terrible word. Genetics is an all-encompassing thing, right? The reason that I'm this tall and the reason I'm this fat and the reason that I look like this is genetics. Well, an embryo also has genetics and a baby has genetics and cancer is caused by genetics, right? So it almost becomes overwhelming. So one of the things that we do here routinely is that we offer the genetic screening of embryos. And what that means is that when someone's going through the in vitro fertilization process, we will offer them the ability to take a look at a bunch of chromosomes, right? We all have 23 pairs of chromosomes, but we're going to offer them the opportunity to look at those chromosomes of the embryos and to figure out which ones are normal or abnormal. The reason that we offer this to many patients and the reason that many patients choose to do this is because with that data, it helps us, the treatment team, select the single best embryo to put back. But more importantly, it helps us help our patients understand their chances of getting pregnant in the future with the embryos they have stored, right? So instead of just having 12 embryos in the bank, maybe now they know they have 5 normal embryos in the bank. Or, for example, if they have 2 girls at home and they want a boy, maybe they want to put back the boy embryo next, because we'll know that from the genetic screening. But most importantly, we will know that an embryo is most likely not going to have Down syndrome or any of these other terrible conditions. And in addition, we can help reduce the miscarriage rate, right? Miscarriages are probably one of the most heartbreaking parts of our job that we see every day. And by using chromosomal screening, we can actually bring the miscarriage rate to a single-digit level, beyond even what someone would have at their age, right? We know that 1/3 of all pregnancies end in miscarriage. That's 33%. That's a big number. But with our screening technique, we can actually bring it down to single digits. And so instead of having a person just waiting for a pregnancy to fail, we can set them up for success from the very beginning.
How do you do that? If you can go into that a little bit.
Absolutely. So what we do is I'll take you through actually what the embryology process is. So once we retrieve the eggs, and I'll tell you today I retrieved 124 eggs between 6 patients. It was quite the busy day. But once we retrieve the eggs, we'll take an egg and we'll clean it off. And in the laboratory, we'll surgically put a single sperm inside a single egg. That's called ICSI, or the intracytoplasmic sperm injection. Once the sperm is put inside the egg then will continue to divide. So it becomes from an egg to a zygote, and 1 cell becomes 2, and 2 becomes 4, and 4 becomes 8. And that's kind of day 3. And in the early 2000s, when I got really interested in this field, we would test embryos on day 3 and take one of those 8 cells. But what we know is that one of those 8 cells is not actually what's going to happen in the end. They weren't the best representation. So instead what we do is we grow the embryo 2 days more, until day 5, when it's something called a blastocyst, and it's hundreds of cells. And we take a little biopsy or sampling of the outside of the embryo, of what would become the placenta. So instead of looking at 1 cell, we look at 5 to 20 cells. And we take those cells and we send them off to our genetic testing laboratory. And for us, we use our lab in Colorado, which I truly think is one of the best, if not the best in the country for doing this. And from there, we're able to do really advanced genetic analyses. We call it comprehensive chromosomal screening, or CCS. And there we can figure out what is the genetic complement of this embryo and what's the makeup of it. The other cool thing about it is that let's say that one of the 2 parents carries like the cancer gene, or one of these terrible genes where, they themselves had breast cancer, or their mother had breast cancer, or their sister had breast cancer, and they don't want their daughters or their future children to suffer from such terrible diseases. We can actually use that biopsy to screen the embryos to make sure we're not putting back an embryo that has that gene within it.
Wow. Incredible.
Thanks. It's pretty cool. I mean, I have to say, every day I walk in here, I'm blown away by what we can do to help people.
Fantastic. Well, you've certainly helped a lot of people.
Thank you.
Thank you so much. So we have another viewer question. They're in the early stage of a pregnancy. They're a first-time mom. They're asking what tips you have to placate anxiety or worry that their unborn child is okay.
Great. So, right, like everyone says, I'm pregnant, but now I'm freaking out. What do I do? So first and foremost, get off the internet. Watch the end of our piece today, but get off the internet, right? Use Google for 2 really good things. One, to figure out which streaming television show to watch. And the second is to make sure that you're looking at all the Haute media things that are being published. Other than that, get off the internet, because all you're going to find are scary things about pregnancy. It's important to know that there are 2 very good registries that are going on right now. The first one is there's the Aspire trial that's running out of the University of California, San Francisco, or UCSF, where they're looking at women in early pregnancy and the effects of COVID-19 on pregnancy. What they have found in their early preliminary findings is that there's no untoward effects of COVID-19 on the pregnancies, there's no increased risk of miscarriage, and we're not seeing any untoward outcomes on moms either. If you look at the data that's been published from Columbia University, my alma mater where I did my residency, you'll also see that people in the third trimester have a very low rate of having complications as a result of COVID-19. It's not absent, but the rates are very low. With that said, I would say just be careful. Avoid exposure to COVID-19. Try to really be careful. Wear a mask, wash your hands, avoid people that you're not routinely interacting with. Make sure you're still exercising, make sure you're still eating well, and stay off the internet.
Great advice. Going back over to the exercise comment there, for someone that is on IVF and going through the process, what are your recommendations on exercise?
So remember at the beginning, I said that, we partner with our patients and our success is our patient's success.
Yep.
Well, I can also tell you that if I didn't exercise, I would go nuts. And so I know for patients, if they didn't exercise, they would go nuts too. So what we always tell patients is ask the doctor at the time of your ultrasound, how do things look? And is it okay for me to exercise at this point? There gets a point where the ovaries start to get really big, right? As a result of the medicine. And when those ovaries start swelling as a result of the medicine, there's a risk that you could actually twist your ovaries. That's called an ovarian torsion, and that's actually a medical emergency. Well, it ends up that you don't have to do no exercise because of that risk of torsion. Instead, talk to your doctor about safe exercises. Maybe you want to use your Peloton or your SoulCycle bike or something like that, but just don't do the jumps up and down. Maybe you just want to avoid those twisting motions, but still do some sort of exercise. So talk to your doctor about an exercise plan that they feel comfortable with during your IVF cycle.
Thank you, Dr. Levine. Who is the most ideal candidate for IVF?
I think the most ideal candidate for IVF is someone who's having difficulty getting pregnant and has reached the end of their rope of using normal interventions. Typically, people think that you have to be under 35 and have an egg count of this and a sperm count of that. And you know what? I don't treat numbers. I treat people. I treat couples, right? We treat people who are having difficulty getting pregnant or staying pregnant. So if I had to really pick who's the ideal person for IVF, it's the person that really needs help getting pregnant, because we're going to figure out the right solution for them.
Thank you, Dr. Levine. Can you kind of talk us through the treatment process as a whole from the beginning to the end?
Sure. So it always starts with something like this, right? I mean, with telemedicine, right now it's frequently starting with a Zoom or a GoToMeeting or sometimes in person. But it starts with really getting a good conversation going where we can learn what someone is doing to understand their own fertility and what they're doing to try to get pregnant or stay pregnant. Maybe they didn't realize that they're actually having a bunch of miscarriages and that's why they're having irregular cycles. Or maybe someone just has really irregular cycles their whole life and they just weren't aware of it. We try to get a good understanding of who the patient is. Next, we have, if it's a couple, for example, we have them come in for what we call the One Day Workup. And I have to say, this is probably one of the best things that CCRM has done is for a long time, our one clinic was the one in Denver. And because it was geographically isolated from most places in the country, people would fly into Denver and they try to get everything done in a day. And so this One Day Workup, we've now expanded to our 11 sites across the country. But what people will do is they'll come into one of our sites and they'll get their blood work done, their ultrasound done. We'll take a look inside their uterus to make sure everything is okay. Their partner will get their semen analysis or their semen studies done. They'll meet with a genetic counselor and they'll get their genetics done. And then they'll go away. And while all that data is cooking, right, the blood work is going off and we're looking at the ultrasounds and things like that, we'll have a plan with the patient for the next kind of 30 days of what we're going to do in that interim. Maybe we have to go talk to their internal medicine doctor or their OBGYN or their urologist or their orthopedic surgeon or someone about, their health stuff. At the end of that couple week process, we have all this blood work back and all this ultrasounds done and this whole workup done. we then typically make a plan. If the plan is to move forward with IVF, we'll either schedule them and say, we're going to have you take a birth control pill for a couple weeks so that you can start IVF on a certain day. Or we'll say, we're going to synchronize your cycle and we're going to have you start on a certain day. Or we'll say, you call us when you get your period and then we'll start IVF at that point. No matter how it starts, it always goes for about 10 to 14 days of taking injections. Now, the injections are about the thickness of a human hair. The needles are small, they don't really hurt. Needles are scary in general, but I promise that after the first shot, people get pretty used to it, and it's really not that bad. In fact, most patients give them to themselves. If they're really overwhelmed by taking the shots, we can either teach their partners to give the shots, or we can help them find a nursing service where a nurse can actually come to them, even during COVID, to help give their shots that they need. Throughout the process of IVF, they take shots for about 10 to 14 days. And during that time, the male partner will be asked to take antibiotics. We'll also ask them to abstain from having sex because we want his sperm to be saved up to be the best count possible. And then they'll have blood work and ultrasound to monitor. And at the end, we do what's called a retrieval procedure. The retrieval procedure for many people is the first time they've ever had anesthesia. The anesthesia that they receive is just like having a colonoscopy or your wisdom teeth pulled. It's propofol, so it's an easy IV. It's really twilight. There's no breathing tube involved. And while they go to sleep, we use an ultrasound with a little needle on it, and we aspirate or suck out the eggs. The eggs are then combined with the sperm in the laboratory, and as we discussed before, the embryos are then grown for a week. The patients tend to go home if they live locally that day, and if they don't live locally, we tend to tell them to stay in a hotel for a day or two and then go home. And then they wait for the genetic testing results to come back. That takes about 2 weeks. The following month, we'd have them come back to put back the embryo. And I'll tell you, one of the coolest things is that right now, there's been a real nice trend across the country, which is a European trend that's really moved to the United States, of doing something called natural cycle frozen embryo transfers. I know that's a mouthful, but basically, we'll let someone ovulate on their own. And then 5 days after they ovulate naturally, we'll put back an embryo from our laboratory that's 5 days old. So we get to limit the number of shots they need, the number of blood work, and things like that. And we're having really good outcomes with it as well. So all said and done, it's about a 60-day process for IVF. It's about a 30-day lead up from when we first meet someone.
How many cycles can someone go through if they're unsuccessful in the first rounds? Do you have people that go to 2 to 3 to 4?
Well, I hope that someone doesn't need multiple cycles. With that said, it's quite possible that either they make very few eggs, their partner has very poor sperm, maybe they have really bad embryo quality, or maybe they even have a genetic abnormality that we're screening for and it keeps popping up in their embryos. So it's not uncommon for someone to have to do multiple cycles. With that said, we really like to see someone less than 5 cycles. Sometimes they do go to 6. And that number comes from the American Society for Reproductive Medicine, where they have recommendations about women who want to donate or sell their eggs. Those are called egg donors. And they do recommend that egg donors do 6 cycles or less of egg donation. So we adhere to that actually for recommending IVF cycles for patients as well.
Thank you, Dr. Levine. What are some of the most common side effects that someone would experience while going through IVF?
So I think we touched on this before, but in vitro fertilization is just like anything else in infertility. It's highly emotional. And so the unintended consequence of much of this is that it's really emotionally difficult, right? There's the 3 costs of going through this process. It's financially expensive. It's physically expensive because you're taking these injections and you might feel bloated or a little uncomfortable and go to the doctor's office a bunch of times. And emotionally, it's expensive, right? It's really exhausting and tiring. And sometimes people just feel sick as a result of going through this when they're really not physically sick, but they're just seeing a doctor all the time. So I'd say the number one side effect is the emotional toll. Physically, sometimes people say that they gain weight after doing IVF. Typically, that weight gain is 1 to 2 pounds of water weight that you'll lose with your period, which happens about 7 days after the cycle. And there's really no lasting side effects of going through either egg freezing or any of these other processes.
Thank you, Dr. Levine. And I know we did touch on this a little bit at the beginning, but what are some of the medical options someone would have for fertilization, optimization, and preservation?
Great question. So, right, this goes back to the male part of fertility that people kind of forget about guys all the time. Right, we look at 4 things when we're taking a look at someone's semen parameters: the volume or the amount of semen that they have, the concentration, like how many million sperm do they have in there, the motility, right? Do they have Michael Phelps swimming in straight lines, or Ryan Lochte, that guy who used to swim in circles and get drunk and lie? And then how pretty are they, right? Beauty's in the eye of the beholder, but we do know that ugly sperm tend to have ugly DNA. So once we look at those 4 parameters, we can figure out if we're actually going to let sperm naturally fertilize an egg. That's called insemination. If we're going to surgically inject a single sperm inside an egg that we pick, that's called ICSI. Are we going to use an advanced selection technique called PICSI, or physiological ICSI, where we're actually going to have a sperm swim around on a dish, and they're only going to pick sperm that attach to a certain part of that dish to then put it inside of the egg? So there's a lot of different techniques that we can use for fertilization, but those are the 3 main ones.
Thank you, Dr. Levine.
Of course.
Closing out over to surrogacy. Who would a proper candidate be for surrogacy?
So surrogacy is a very interesting topic in general because it feels like it's becoming much more of an open conversation. What's amazing to know is that even though I practice in New York City, and New York, which is really the IVF capital of America, right? More fertility clinics are in 5 square miles of where I'm sitting than anywhere else in the United States. Surrogacy is still not legal in New York. In fact, it won't be legal in New York until February of 2021. With that said, as the conversation of surrogacy starts normalizing, and the fact that we have 11 clinics across the country, we get this question pretty often. In looking for the ideal surrogate is you want to find someone that you feel comfortable with. You need to understand that this person's going to partner with you to help you grow your family. You have to know that you feel trusting in them and that they feel trustworthy to you. In addition, you have to make sure that they are medically healthy, that they've previously carried pregnancies to full term, and ideally you'd love to know that they did this before, at least once before, and that there were no complications of getting them through a cycle of surrogacy. It's a pretty difficult conversation to start, but what I would say is that most reproductive endocrinology and infertility specialists like myself are comfortable going through the pros and the cons of surrogacy and who are the best surrogates to use.
Thank you, Dr. Levine. Going back over to our previous conversation, back over to sperm. Are healthy sperm associated with healthy babies?
So we hope healthy sperm are associated with healthy babies, but what we do know is that when it really comes down to it, sperm are just missiles of DNA. And in reality, the egg holds all of the magic. The egg has all of the machinery to become the future embryo, right? The sperm is just the DNA from the dad. So part of the equation is starting with healthy sperm. But we know that it takes healthy sperm with an opportune or the best egg possible to get the healthiest outcome. But it is a very important part of the equation.
Thank you, Dr. Levine. And talk us through the process. I know surrogacy isn't legal there in New York, but if you can just kind of quickly touch on that.
Sure. So it's always important for people to understand that surrogacy could be written in big letters, but directly under it in little letters should be written lawyer, because it all starts with legal. And you have to make sure that you have a really good agency that's helping you match with your surrogate, but you also have a really good lawyer that's going to help you, because many of the surrogacy laws in the United States are on a county by county basis. It just doesn't matter the state that you live in. It matters the county that either the transfer occurs in or where she delivers. So you have to make sure that there's good legal representation and there's good contracting. What happens is that typically someone creates embryos first, and once they create embryos, they make the decision that they're going to use a surrogate. They reach out to an agency, which is a very fancy word for a headhunter, and they find a surrogate who matches certain criteria that they're looking for, maybe geographic or socioeconomic or whatnot. They find a surrogate, and then they have that surrogate evaluated. That surrogate typically is evaluated at a fertility clinic, sometimes the same clinic where the embryos were created, or a different clinic where the transfer might occur. And they're evaluated on a general health, a psychological health, and a uterine health. You want to make sure that it's going to be a good womb, that the person is stable, that they're going to adhere to everything. You want to make sure they're just generally healthy overall. Once those three things are completed, then you walk down the road of even further with the agency of the contracting. Typically, from the beginning to end of deciding to use a surrogate, it takes about 6 months until the transfer will occur in a surrogate.
Thank you, Dr. Levine.
Of course.
And thank you so much for all the time that you've spent with us today. What are some final thoughts that you'd want to leave our viewers with?
I think the big takeaway is that you're not alone if you're dealing with infertility. Everyone thinks about coming to see us for trying to get pregnant. A lot of young women think about coming to us for freezing eggs. But I also say, don't forget about that messy middle group, that second group in the middle that we treat that no one really talks about, which is that people have trouble staying pregnant, that miscarriage group. If you find yourself in that community of people who have really hard time staying pregnant, you should know that there are doctors like myself who are out there who are happy to help. And you're not alone. And I really have to commend some of the people who've come forward with their terrible miscarriages, such as Chrissy Teigen. And most recently, I think we just saw the royal couple in California talking about their miscarriage as well. And to understand that, miscarriages are a common event. With that said, fertility seems really easy and really natural, but it's also really normal to have issues. 1 in 8 couples will struggle. So when in doubt, get help. Thanks to the pandemic, we're all around. I'm seeing more patients than ever. And thanks to Zoom, I'm able to see patients earlier and later and on the weekends. And, we're available and we're around. So what I'd much rather is that someone calls to make an appointment to ask some questions than Googling themselves to a dark hole, right? I find myself de-Googling people all the time because the internet is just a really weird place. But most importantly is take a deep breath. There's a lot of really good fertility doctors all over the country. There's a lot of really good people who are out there to help you. All you have to do is just ask for help.
Thank you so much, Dr. Levine. What a great session, great information. Thank you. Thank you for your partnership.
Thank you. And thank you again for supporting us. I mean, I have to say that, as a member of CCRM, it's really awesome to be part of a network, right? We have 11 clinics across the country. Our patients have moved all around from New York to Boston, to Atlanta, to DC, to LA, to San Francisco. And I do have to say that during this pandemic, it's been wonderful that, we've been able to still take care of our patients with our partner clinics. But more importantly is thank you for partnering with us on this one, right? Because the biggest thing is that we find the biggest hurdle to people getting treated is getting educated. And so thank you for helping us, reach new patients, reach out to patients and address really some great questions this evening.
Well, thank you. It was, it's a true honor to work together with you and a real pleasure. And thank you for everything that you shared with us.
Thank you.
Hour. Really appreciate it. And, to you and your staff and your family, hoping you all stay very healthy and safe. And before we close out, could you share your social media handles with us?
Sure. So you can find me on Instagram at Dr. Brian Levine, Dr. Brian Levine, and it's the same for Twitter and it's the same for Facebook. I'm just going to warn you that if you go onto my Instagram, there's probably lots of pictures of my cute little 3-year-old, because she's my real motivation for what I do every day. Because I know how important it is to have a family. And so it's really my greatest pleasure. But Dr. Brian Levine on Instagram is where you can find me.
Thank you so much. And your site and your office line would be great for you to repeat as well.
Sure. So you can find us at CCRMIVF.com. That's the Colorado Center for Reproductive Medicine. It's one way to use Google, is at least to look us up there. And you can call our phone number at 212-290-8100 or 212-IVF-CCRM.
Thank you so much, Dr. Levine, and thank you for all the good work that you do.
Thank you again, and thank you for featuring us. This has been a lot of fun, and I look forward to doing another session and answering all these great questions again.
Likewise. Thank you very much. Have a great rest of your week, and looking forward to seeing you very soon.
You too. Bye-bye. Stay safe.
You too.